My name is Emma Nye. I am from Indiana State University in the Doctorate of Athletic Training program, and I'm going to talk about my ankle decision making, a critical reflection. So my current evaluation really depends on the time allotted with my patient, particularly at the ankle. As we talked a little bit about this week, clinicians are generally confident in this area. It's the first thing we learn in our evaluation class as an undergraduate, and it's one of the most common injuries seen in clinical practice. So I do feel confident in my evaluation skills of the ankle, although there is always room for improvement. But when an athlete comes in and they quote-unquote tweak their ankle, or maybe I saw the mechanism and they got back up and kept playing or kept practicing, usually my evaluation is quick and to the point. And now if I have, say, 20 to 25 minutes for an evaluation and I'm just seeing this patient, I am definitely more thorough. So right now my current evaluation, pretty standard in terms of subjective and objective portions. So if an athlete comes in, usually I start right off by saying, what happened? Tell me what was happening out there. I ask about the mechanism, and I usually do a pain scale on the visual analog scale. If it's a re-evaluation, usually I use the global rating of change. I ask about previous history of ankle pathologies, but also knee and hip pathologies to involve the kinetic chain. My objective portion, again, pretty standard. Range of motion, palpating the malleoli, the lateral ligaments, the medial ligaments, and then the tib and fib. Usually I perform anterior drawer, Kleiger's, squeeze test, talar tilt, and then I usually do a functional test. This is either a single leg heel raise, a double leg heel raise, a single or a double leg hop, just to assess function. And my undergraduate, I think, did a pretty good job of training its clinicians to use the Ottawa ankle rules. The Ottawa ankle rules were presented in our evaluation class of the lower extremity, and then they were also reiterated in our clinical class, and they were referenced many times in the handbook that we use for class. So I feel pretty confident. I would say 75% of the time I'm using the Ottawa ankle rules, particularly for a grade 2 or grade 3. And then, like I said before, if I have a bit more time for evaluation, I may use a PROM, but if it's just a quick 5 to 10 minute evaluation the first time, I'm usually not using a FODI or the FAM. So why are my current evaluation skills the way they are, particularly right now? My subjective portion really, sometimes it doesn't really change. The way I approach an evaluation usually is similar across the board, whether it be an ankle or a shoulder. The subjective portion is pretty typical. It gives me information on mechanism, previous injury, activities of daily living. Is this affecting work? Is this affecting school? And then the site of pain and perception of injury with the PROM. And then my objective portion, I would say the special tests, range of motion gives me information about the integrity of the structures, volleyball specific tasks, the Ottawa ankle rules giving me information about referring for an x-ray or not, and then the PROM with values and perceptions. So when reading the literature for this week and reflecting back on my own clinical practice, I identified at least 5 areas of improvement. So typically, I do not re-evaluate, especially for a grade 1 lateral ankle sprain, 4 to 5 days post-injury. Although the literature does suggest that a delayed physical exam gives a better diagnostic result than within 48 hours. So although that I think my evaluation within the first 12 to 24 hours gives me a lot of good information that's important and absolutely needed, I also need to follow up 4 to 5 days post-injury. My second gap, I would say, is the use of range of motion with a goniometer and then its associated documentation into sportswear. Usually when I do range of motion at the ankle, it's, okay, go ahead and pull up, go ahead and point down. It's typically plantar flexion, dorsiflexion, inversion, eversion, just through visual inspection. Although the literature does suggest limited dorsiflexion and reduced propriocepsis leads to an increased risk of lateral ankle sprains. Thirdly, I think I can do a better job of assessing gait, as normal heel toe may be replaced with heel raise when differentiating between a lateral ankle sprain and syndesmotic ankle sprain. Although I do think I assess gait to an extent when I'm doing Ottawa ankle rolls, that's only 4 steps. And then 2 tests that I thought were really interesting and absolutely helpful in clinical practice, the cross-leg test and the point test. I've actually never heard of these tests. Pain in the distal syndesmosis suggests presence of injury, so those are 2 tests that I can use to differentiate between the 2. And then obviously sonography, some literature suggesting it can cut down on athlete exposure to radiation, although there's been some conversations at ISU AT Services about diagnostic ultrasound. We do not have one right now. So what can I do to close the gap? I think a first initial step is just to always reevaluate 4 to 5 days post-injury, whether it be a grade 1, a grade 2, or grade 3 ankle sprain. This clues me in on a bit more information. Not just progress notes, but complete reevaluation. Secondly, I can use a goniometer rather than just observation when recording range of motion and recording it into sportswear. An actual objective measurement rather than just visual observation. Thirdly, while performing Ottawa ankle rolls, I can have the patient walk further than 4 steps and observe bilateral gait patterns. That'll clue me in and differentiate between the lateral ankle sprain and the syndesmotic. Fourthly, I can do more to rule out syndesmotic injury by practicing and actually applying those 2 tests I talked about. And finally, I can continue to have conversations during the staff meetings when the topic's brought up about the diagnostic ultrasound to cut down on that radiation. But arguably, I think the most important piece of this closing the gap is to include my student. When we have conversations with our students about new techniques and new evidence, it's one thing to have conversations about and kind of clue them in, but if I'm not actually performing them on patients to improve patient care, I'm not being a good role model. So if I can explain all of these things and its importance and the literature behind it, but then also act as a role model, that will hold myself accountable as well.